What are the risks of post-ligation bleeding? Well, post-ligation hemorrhage usually occurs between 5 and 10 days after the procedure. It is thought that separation of the ligated hemorrhoids leaves an exposed blood vessel which can cause excessive bleeding and can be life-threatening. Patients should be instructed to call immediately should they experience excessive bleeding after the ligation procedure. In addition, all blood thinners and/or anticoagulants should be discontinued for at least 10 days beforehand. This includes aspirin, Plavix, Coumadin, warfarin, for example. Anticoagulants should also be discontinued for 10 days after the procedure. If the patient has a known bleeding disorder, an alternative treatment method should be considered. What are the risks of pelvic sepsis? Well, pelvic sepsis after hemorrhoidal ligation is a rare but recognized complication. There are a handful of case reports in the literature of pelvic sepsis following ligation. Pelvic sepsis can sometimes be attributable to previously unrecognized immunosuppression, such as HIV or AIDS, or immunosuppression due to malignancy, chemotherapy, and other causes. Patients should be evaluated for any potential immunosuppressive disorder before they are considered for hemorrhoidal ligation. Alternative methods of treating internal hemorrhoids should be considered in the event the patient is found to be immunosuppressed. What analgesics are required after the procedure? Well, generally, patients experience only a mild cramping sensation for about 12 to 24 hours after the procedure. The best remedy is to soak in a tub of warm water which relaxes the internal sphincter muscle, which is the usual cause of the cramping. Patients should take Tylenol every 4 to 6 hours if they experience any discomfort. Significant discomfort following the procedure is rare, and patients should be advised to call the doctor's office if this is experienced. Do patients see the internal hemorrhoids slough off? Usually not. Occasionally, patients pass a small amount of bloody mucus which may represent the residual hemorrhoidal tissue. Most frequently, patients are unaware that the hemorrhoid has sloughed. What happens if the patient experiences persistent symptoms such as bleeding or prolapse? Well, patients occasionally experience a small amount of anorectal bleeding for several days up to a month after the procedure. Patients should be reassured and instructed to continue with their fiber supplements and copious liquids. This minor bleeding may be sometimes due to healing of the residual ulcer after the hemorrhoid is sloughed. If patients experience significant bleeding up to 2 or 3 months after the procedure, then the patient should be re-evaluated. If persistent internal hemorrhoids are identified, repeat ligation should be offered. Are patients with both external and internal hemorrhoids candidates for rubber band ligation? Well, the answer is no. If patients have associated external hemorrhoids as well as the internal hemorrhoids, they're at high risk for developing edema and even thrombosis of the external hemorrhoids. Patients with moderate or large external hemorrhoids may require surgical hemorrhoidectomy to remove both the internal and external components. Are patients with fissures good candidates for hemorrhoidal ligation? The answer is no. Fissures cause excessive pain, and this will be greatly increased if the hemorrhoids are ligated. Is it safe to ligate all 3 hemorrhoids at the same time, rather than ligate one at a time? Well, the answer is yes. Prior studies have demonstrated the safety and efficacy of ligating all 3 internal hemorrhoids in the same setting. In the series of 500 patients reported by me, there were no serious complications. It's a sensible precaution to avoid all anticoagulants for at least 10 days beforehand and to carefully screen the patients for any potential immunosuppressive disorder. Patients with large external hemorrhoids, fissures, Crohn's disease, etc. should be considered for alternative treatment methods.